Hello everyone, good afternoon and welcome to the Health Overview and Scrutiny panel. I'm Councillor Mark Jeffrey, Chair of the panel. So firstly, just some housekeeping safety information. If the continuous fire alarm sounds, please evacuate the room and public gallery by the stairwells. Do not attempt to use the lifts. Please assemble at the Queen Victoria statue in Guildhall Square. In order to comply with the Guildhall Trust fire marshal regulations, anyone who has signed in at the Guildhall reception desk should sign out when leaving the building at the end of today's meeting. So may I draw everyone's attention to the fact that this meeting will be live streamed. Everyone speaking via microphone will be on camera. Members of the press and public are also permitted to record the meeting on the understanding that it neither disrupts the meeting nor records those stating explicitly that they do not wish to be recorded. Please can everyone use the microphone and remember to switch them off when they have finished. Okay, so can we have introductions around the table, and I'll start from my right, please.
Hello, Lisa Gallagher from Democratic Services.
Councillor Graham Heaney, St Jude Ward, Portsmouth, Labour Councillor.
Councillor Jonathan Williams from Bishop's Waltham, representing Winchester City Council.
Councillor Leslie Minahan, representing Hampshire County Council.
Councillor Lee Tyndall, representing Copner, Portsmouth.
And welcome to your first meeting as well. Thank you. So members have read the report, so presenters, please just highlight any developments that may have occurred since publication. I've got apologies from Councillor Gardner, Councillor Oliver, Councillor Harris, Councillor Raffaelli, Councillor Vivian Ashwell, Councillor Jonathan Williams is deputising, and Councillor David Evans. So does anyone have any declarations of interest? This is agenda item 2. Jonathan.
Thank you, Chair. It's the same declaration as the last meeting in that my personal interest in that my employer is a consultant orthopaedic surgeon at QA.
Any other declarations? Thank you. Agenda item 3 is minutes of the previous meetings. So I'll go through the minutes, and if members have any corrections, please indicate. So page 3, page 4, 5, 6, 7. I've indicated that there's the words does not are missing from the bottom third from bottom paragraph, second line. So it should read, members felt that this does not reflect. So that will be corrected. Any more on page 7? Page 8, 9, and 10. Okay, so with those corrections, I'll sign the minutes. Thank you. So the first main agenda item is agenda item 4, which is Hampshire and Isle of Wight ICB. So we've got Caroline Morrison, Bernie Allen and James Roach. Would you like to come forward or you can all come forward if you like and sit here, but could you give us a brief summary of your report and then members will ask questions? Thank you. Would you like to introduce yourself so we know, as everyone knows, so the new members here?
Yes, of course.
Thank you.
So good evening, everyone. I'm Caroline Morrison. I'm the Chief Strategy Officer for NHS Hampshire and Isle of Wight.
Hello, I'm David Bailey. I'm the Deputy Finance Director at the ICB.
Bernie Allen, Deputy Place Director, Portsmouth, NHS Hampshire and Isle of Wight.
Thank you. Just before you start, I forgot to say that Councillor Vernon Jackson might be late, and he has just arrived. Do you want to just quickly introduce yourself?
Hello, I'm Gerald Vernon Jackson, one of the Portsmouth councillors.
Okay, back to you again. Apologies for that.
Thank you very much. I'm mindful of your sort of ask around just sort of focusing on areas of update, and also apologies to Councillor Minahan, who's already heard some of this at the Hampshire Hask. So we've got a number of areas of focus in front of you. I was going to do just a quick bit of context and sort of next steps around the work that we've been doing on our renewed ambition. David, who's my colleague, will talk to the elements of the finance paper. And James to primary care, and hopefully all of this you'll see will align very much with the work on the health and care Portsmouth paper as well. So that's the aim. So just very briefly on the work around renewing our ambition. So this is a piece of work that forms the system strategic plan for NHS partners in Hampshire and Isle of Wight, and it really builds off the work that we've done over the past few years with our partners around looking at what our ambitions for transforming outcomes for health and well-being of our population is across Hampshire and Isle of Wight. So hopefully members are familiar with the Integrated Care Partnership strategy, which was developed in partnership with colleagues in public health and local authorities, and focuses very much on prevention, proactive care, and all of the work that we want to be doing to help keep people well, keep people engaged in their communities, and where there is a need to access more acute care, that care is given in a timely, appropriate and expeditious way. So the work that we've done around renewing our ambition really focuses on what does that look like as a system, what's the work we've done in the last year, and going forward, how do we want to make some really clear strategic commitments to what we're going to do as a set of NHS providers and system partners to change the way that we're able to deliver care for our partners. So there's 5 statements within that. So, if there's nothing else in the report, I think those 5 statements are the kind of key for us now going forward. So the focus on preventative proactive care, on person-centred care, on making sure that we're focusing on clinical outcomes and data to drive improvement, and working through our models of integration and collaboration, and also really importantly how we learn from each other and how we really scale and adopt things that are going on across all of the patch. And that brings me to the other point, which is this is about looking at how we add value as a system. So we know that there's lots of good work, and the paper that Bernie and Helen have done around health and care the health and care Portsmouth work draws on some details around that. So there's lots of things happening within our places. But this is our opportunity to think about how we learn, draw on those, and deliver something across the system that adds value. So the next steps to this really are to put some measurable, tangible outcomes against those statements. We're also using it as part of our planning round. So we're starting already to think about planning for 25-26, and David will talk a little bit more about that. To really say, well, if these are the things we say as a system we're going to do, what does that look like tangibly with regards to, in the first instance, 25-26, but actually in the longer term, because we know to deliver some of those big shifts of care, think about prevention, it's more than a one-year cycle, and that's often one of the challenges we have as the NHS, is we tend to run in one-year cycles, but actually to do what we really want to be able to do, and which is focus on health and well-being, we need to think beyond that. So that's a really important piece of work that we will look to do going forward, and we will absolutely be doing that in partnership. So I know this is also on the Health and Wellbeing Board agenda, so making sure that all of the things we're doing in collaboration and focusing on the areas that are important to our local residents. So as much as this is looking at sort of system working, it's how we can have an impact into those important areas around inequalities and the integration and the work that we can do to underpin that going forward. So that was all I was going to say, other than just to reference the fact that people may be aware that the Darcy review was published last week, and hopefully that aligns with a lot of the themes that we've also identified and drawn through. So actually, I think it sort of strengthens our position within the system to say that all the things that we're doing and we want to commit to are also part of those national commitments, and with the sort of thinking emerging from the government going forward, hopefully all of that will align and give us a really clear set of pathways. So that was all I was going to say on renewing our ambition. Obviously, very happy to take questions, but if I hand to David to talk to the finance element of the paper.
Thank you, Caroline. Yes, so as you may be aware, that the Hampshire and Isle of Wight ICS is subject at the moment to the financial recovery programme from NHS England. So we generally spend best part of £4 billion a year on the health of our population within Hampshire, Isle of Wight, ICS. And we're focused mainly on the likes of urgent care, planned care, primary care with our GPs, prescribing and continuing healthcare. Now, our plan for the current year is to spend £4 billion. Our actual plan is for a deficit of £70 million against that. Okay. Now, I'll get the main reasons for that are sort of well known in terms of particularly our growth in staff over the COVID period. We do have a reliance on escalation capacity to meet the high demand we have, and in delivering our cost improvement programs. So that is our challenge for this year. In terms of scale, Portsmouth in itself is probably 10% of the ICS. In terms of we spent about 400 million for our population in Portsmouth last year. One of the things that I did want to highlight is around the work we do within the Better Care Fund. With both local authority partners and NHS partners, we spend £54 million within the Better Care Fund, where we both contribute to joint projects around supporting carers, community equipment. There's units we've set up around Jubilee and Spinnaker. There's the sort of very well thought of Portsmouth Rehab and Reablement Service, and just general discharge to assess services. So we work through quite closely with local authority colleagues to do that. And in terms of capital, there is an ambitious capital programme within the ICS. Highlights for Portsmouth would be the new emergency department at QA, and some community diagnostics that we have in Portsmouth as well. So yeah, that's a sort of overview of our financial position, the type of things we spend our money on, and roughly where we are in terms of our overall financial position. Anything else to add? I think that's all.
Is there anyone else? Do you want to speak? Yeah.
Yeah, thank you, Chair. I'll just give an update on primary care, and it builds on from our last discussion in July. So I come with positive news in terms of the number of appointments that are being managed in the city. July saw a record number of appointments for our GP practices, a 27% increase on July last year. Now, I'm not suggesting that increased demand is a good thing, but I think we should reflect the good work our practices are doing to stand up to that demand and ensure people are being seen quickly. There's also a 15% increase in the first 7 months of this year compared with last year. And I think for the first time, third month in a row, Portsmouth doesn't have the lowest number of appointments per 1,000 patients. So whilst we're not where we want to be, I think the improvement is clear from the statistics. I think the numbers suggest both the ability of practices to sort of stand up to that demand, the diversity in terms of service access, and the innovation that they're taking forward. And I do reflect the Pharmacy First service in the report. I think there's been some really good work taking place between general practice and community pharmacy in terms of referring people with minor illnesses and minor issues to pharmacy for treatment moving forward. There is data in the pack which reflects on an overall level what we're achieving across Hampshire and the Isle of Wight. All community pharmacies in Portsmouth have signed up to the scheme. There was a request at the last meeting for that data to be broken down by pharmacy in Portsmouth, and we are pursuing that, and I hope to update on that at the next meeting. And I think the other point to make in terms of what we're doing in general practice and what we're doing in pharmacy is we've got a primary care access recovery plan, which is a national programme. So we're demonstrating strong delivery against that, and it may be, Chair, that I bring an update on the plan to this committee. We're starting to invest more in general practice resilience. So we're having a number of conversations with our practices in terms of what additional support do they need to meet demand in a variety of different ways moving forward. And as reflected last time, we've invested in a range of digital phone line options, improved access for people virtually, and we're starting to look at where we can develop that modern general practice offer in line with the National Development Plan of General Practice. So that's an overview in terms of the service provision. You'll also note in the report there's an update on the GP practice survey. I think at the last meeting, councillors requested an update on patient satisfaction, and the headlines from the patient survey are outlined in terms of overall experience, confidence and trust within their GP, and the number of people who recorded a good experience of community pharmacy services. So still a lot to do, but I think the improvements are clear, and there's an absolute commitment to support our practices, both in terms of core delivery moving forward, but looking at where we can innovate services. Caroline made reference to integration and the renewed ambition. Some of the work that we are taking forward in Portsmouth will be around the development of integrated neighbourhood working. There's a good platform in Portsmouth for that, and we're seeking to build on that further to ensure that our practices can integrate with community services, social care and our acute trust partners moving forward. So that's the update, Chair.
Thank you. Did you want to? Okay. So members, do you have any questions? And the way I quite like to do this is that if you've got a question on a particular issue and want to follow it up, you know, let me know and you can follow it up straight away, and then we'll open it up to other members to follow up on the same issue, but then come back to you if you want to talk about, if you want other questions, if that's okay. Councillor Vernon Jackson.
Chair, it's all right. Can I do this in two bits?
What? Not like how I've just asked.
Well, no, because I want to keep personal away from strategic.
Yeah.
So, my experience of the NHS at the moment is extremely raw and very personal, and my husband is in and out of QA for the last 6 months, and that's given me quite an, I hope, not an insight that's very good, and I hope I'm unrepresentative. So the talk in your thing about patient-centred care for me is laughable, completely and utterly. So my experience has been of being unhappy with care because I'm got the connection and going to have a meeting with the chief executive about the care of my husband, then having a meeting with
Gerald, sorry. We
I
mustn't talk about personal cases.
Well, okay, but I need okay. So having a meeting where the senior matron of the hospital chaired a meeting to come up with a plan of discharge, and the next day, with no consultation at all, no information, that was completely changed. So I think the idea, and I've had it again today, so the idea that in any way the views of patients and families are of any relevance to how the NHS appears to run, I think is laughable. It is a bureaucratic system, and even our experience is that it's not possible for doctors to speak to each other. They just don't do it. So if you're wanting to try to make stuff person-centred, and you have a massive hill to climb, because it is completely the opposite at the moment. In terms of that, having let that get off my chest, some other sort of more wider things. One of the things that I see, having sat from ages in A&E and then in wards, is there are an awful lot of people who are there to have intravenous antibiotics. And often they're people whose normal place of residence is a nursing home. And it seems to me that that's an enormous waste of resource. You've got people being cared for by trained nurses, and yet those nurses are not allowed to do intravenous antibiotics. If they were, and presumably there have to be a level of training, that would seem to me to free up an enormous number of beds in hospital, which could be much better used. What's the issue with doing that? Question one, pregnant pause.
So thank you. And first of all, just very sorry to hear that of your recent experiences. So I can take on board that sometimes it absolutely doesn't feel like the NHS is person-centred. That's one of the reasons why we have it in the ambition. So, you know, I can I can hear that. I think on the IV antibiotics front, so one of the things that we are doing, and what we didn't actually talk about, is the 25-26 planning. So we're starting to think around what some of those opportunities are, because you know, we are, apart from anything else, we should be helping people access care in the best setting for them, and actually being in a hospital environment to access something that could be done where they would usually reside, whether that's in a nursing home or actually in their own home, it is absolutely something that we have to address and be thinking about, because it's not a good use of resource in terms of the hospital, but it's absolutely not the right experience for the individuals as well. So at the moment, one of the things we're doing is looking across all of our services collectively and identifying where we do have some opportunities to do some of those things differently. Now, nursing homes obviously have a specific contracting arrangement in terms of the level of staffing and what the skills and capabilities around those nursing home staff might be. But there's also something for our sort of community nursing teams as well, about how they could potentially offer that support into people's own homes, and or support nursing home staff to also be skilled up and able to do that. So IV antibiotics in the community absolutely is an area of opportunity to be thinking about for all of those reasons. So yeah, that is something to consider.
Councillor Jackson, do you follow up on that? Yeah.
I don't have a follow-up, but I have different questions. But I shall leave it for others to leap in, and I shall wait my turn.
Okay, thank you. Councillor Heaney?
I wanted to ask 3 questions on 3 slightly different topics, so I'll take the first one, which is just really to get a brief understanding of paragraph 6.1. You talk about additional assurance and reporting requirements and controls around decision making for the ICS. Could you briefly explain what that means in practical terms for you? What are you controlled for?
Yeah, so, so various things that we do now that we previously hadn't is we have a spend and control panel within the ICB, so that anything over £10,000 that needs to be spent needs to go through, has to have a paper return, has to have a finance sign-off, a quality sign-off, and employment diversity impact assessment. It would then go to the panel of our, a minimum of 3 of our executive directors to review that, to make sure that to how we're going to spend that money. So there's that extra step so that's part of trying to get on top of our financial challenge as part of the recovery programme. We then have internal recruitment panels within the ICB to assess each panel and to make sure that to each post that needs to be recruited to, and we're in the process of cutting the staffing quite significantly, and any new posts that need to be approved go through that process. And in addition, through the system, so that all of the providers within the integrated care system, we have a recruitment vacancy panel weekly, so that any non-medical or non-clinical post that want to be recruited to in any of our providers or at all needs to go through that panel, where you've got a selection of people from each organisation, and there's a check and challenge within that. So yeah, the restrictions that we are under in terms of making sure that we review fully the money that we're spending, and like I said, we've got 4 billion, so it's about getting the best value for money out of that 4 billion, and some of those processes ensure that there's sufficient check and challenge before that happens.
Yeah, that's useful factual information, because I wasn't quite sure how it worked. I'll stick on the finance, because I got on to paragraph 6.8, and you talk about the projected deficit. I think you said in your introduction it's now 70 million, not 67, and you've had a £13 million variance. Now, obviously, 70 million...
Clarify on that, the 67 is the year-to-date position, the 70 is the forecast for the full year. So that's the sort of difference.
Right, so you're anticipating that it will go up by another 3 million by the end of the financial year, which will be next March. Yeah, okay. So, I mean, 67 million is a lot of money, but in context of 4 billion, it's not quite so much. I suppose the question I have is this a one-off, or have you got anticipated deficits in future years you're going to have to deal with as well?
Yeah, so the big challenge that we have that we want to get to before we get to the end of this financial year, and if my CFO was here, this is what he would be saying, is that we want to make sure that we get to a run rate balance before we get to the end of the financial year, so that our run rate, so how much you spend each month, is breaking even going into the next financial year. So whilst we may be overspent by 70 million at the end, as you can see from the year-to-date position, it's quite front-loaded, and a lot of our transformation projects and some of the controls that I mentioned earlier, they will get us to our run rate balance for the start of next year, and that's what we're all working to within the ICS.
That sort of sets up my third question, which is about paragraph 6.7, where you talk about your budget, 48% being spent on acute services and the ambition to shift towards community primary care services. We've been saying this for the last 20 years or more, that we want to shift from acute to community, but we're still not there. And the main problem, it seems to me, is we're dealing with, if you like, legacy health issues, which our population is now coming into the hospital system. And that prevents us from dealing with, reducing the cost, because we're dealing with people who were born 20, 30, 50, 60 years ago, whatever. So what confidence can we have that you are going to be able to do that? Because in a sense, I suppose, you're going to have to spend more money on community services while we're still dealing with a legacy of ill health that is currently going through our hospital system. So how is this going to be done? Because your budget situation looks pretty grim, and you're talking about break even. So how is it going to happen?
I think that's been the question that we've been working through ourselves, and that's where the work around renewing our ambition really ties in closely to the work that we're doing around finance, because there absolutely is a will to shift focus and resource into that proactive, preventative space to better address some of those long-standing needs that we have in our population. So James talked a bit around the integrated neighbourhood teams earlier. I know that there's been lots of foundation work for that in Portsmouth for that very reason, but it's something that we are ambitious for across the whole of Hampshire and Isle of Wight as well, to learn from some of those good models and to support, therefore, the focus on what's the infrastructure, what's the approach, what's the model of care of getting into some of those early prevention work with our population, right the way into children and young people, because actually even when we're thinking about adults, a lot of the time it's too late in terms of thinking about those drivers of ill health. So working with our local authorities, our place partnerships, and then I think how that sort of transacts into the work that we do around planning is to be able to have a really robust, strong case to say, if we do this here as a system, this is the impact it's going to make. So let's be brave and commit our resources to doing that, probably in a way that we maybe haven't done before as a system. So for me, I think the combination of the work that we've done around the strategic intent of the system, where we are with some of the conversations around the finance, and then the really great work that we've had going on around the design of those integrated teams starts to come together. And then the other bit of it as well is our work with our partners around the public health agenda, so how we also try and look as much as we can at the early years, at the smoking cessation, at the alcohol work that comes with that. So that's what we're going to be embedding through 25-26. But James, I think you wanted to...
Just to give some more confidence, I think we're at the stage now, certainly with our data, we've got a really good understanding of those patients who could and should be managed in a different setting. So from an intelligence perspective, things are a lot clearer. And I think what David said about the financial planning process is that most of our transformation and our proposed transformation is very much written with that ambition in mind. How do we do more out of hospital? How do we be more ambitious in terms of clinical management? And I think it's fair to say that's the test in terms of return on investment. Yeah. So that is the opportunity that we've got to focus on.
Just a quick follow-up comment. I mean, I understand your ambition, but I also understand the challenges you face. It is really difficult to do that. It'd be helpful if you, in future meetings, as we go through years, you could provide something that can measure what the impact and success of that is, because I think that's really important to be able to, we can talk about it, but sometimes it's very difficult to get a grasp on whether the things we do actually do make the impact. You know, smoking, we've already got issues around obesity with young people, and challenges to try and prevent smoking, you know, face all sorts of obstacles, etc. So some way of you sort of demonstrating to us that it is actually working would be quite helpful, I think. But that's the last comment I make. That's my last question as well.
Thank you, Councillor Heaney. Next, I've got Councillor Vernon Jackson.
Thank you. Slightly less emotive, and just bits of feedback. The Summerley unit, in terms of discharge to assess, was brilliant. I do hope that you're keeping all the beds there occupied. I had heard that there was potential to cut the number of beds, which I hope isn't happening, because it was absolutely excellent. Do we have any figures in terms of failed discharges? Because there is always the talk about the revolving door, that somebody goes out and is counted as a discharge, they come back in again 6 hours later because the discharge has failed, and that's a new patient, and that gets counted again. Do you have any figures on that? And I've had a query from somebody worried about dementia services and specialist clinical nurses losing their jobs. I wonder if you could tell us any more about that.
So just on that, so I'm afraid I don't have the numbers on the failed discharges off the top of my head, but it is something that we do count. It's part of the, you know, as much as we want to speed up discharge and make sure people get home in a timely way, what we don't want to do is send people out without the right infrastructure and support and elements around that. So it is something that I know the hospital also looks at on a regular basis, and we look at readmissions rates as well. So that is all.
I think I'm on my 4th failed discharge.
Yeah, and unfortunately that, you know, that is something that we see through sometimes in the figures. So it is absolutely something that is monitored and looked at. On the specialist nurses, did you want to take that one, Bernie?
So Rowan's has given notice on that element of a very specific contract, and they gave notice and that service has ceased. We have put in place a range of alternative access points for people, including continuing to use the services that are available for more general pathways at the Rowans. As an ICB, we recognise that all of our charitable organisations are under significant pressure, particularly post-COVID, in terms of their dropping donations and the share of the money that they get from donations. And we are continuing to work with them, and indeed did provide cash flow support to Rowans, an additional emergency grant to them to support them stay in operation for this period of time.
And Summerley, which is wonderful.
So we're actually in the process at the moment of looking through what the capacity is that we need going into winter, because obviously we've got those pressures coming up. So all of that's being looked at as we speak in terms of how we plan for the future. So not a decision yet, but it's an ongoing process.
Can I just pick up the Rowans bit? So my understanding is that with most hospices, about a third of their finances comes from the NHS, and therefore they provide an incredibly good and cost-effective service to the NHS. Has the grant to the Rowans been going up or down?
Yeah, so as well as the normal grant, it has been going up in terms of, as well as the normal grant, we've given them an extra significant sum this year because of some of the issues that they've got. Clearly, and as I said earlier, the big challenge we have, and I feel sometimes less like a finance person and more like an economist within this, it's about getting the best value for the money. So we could put a lot more money with the hospices, but we'd have to take it from somewhere else. So it's how you make those decisions is the thing we grapple with on a daily basis, of where is the best place to put the money, which is helpful coming to situations such as this that we get some direct feedback and we can build that into our plans going forward.
Are there any more member questions relating to this issue? Yeah. On this issue?
It's on the Rowings one, yeah. I mean, I understand, because I've had some correspondence about this as well, that you're intending to re-tender the service, but are you intending to re-tender it in the new financial year, i.e. after March, or are you going to re-tender it, like, now?
I don't know off the top of my head from that. We deal with many contracts, and I don't have the details of each one to hand at any one time, but we could find that out for you.
If you could, that would be useful, yeah.
Any more member questions on this issue? No, this issue. No. Okay, going back to finance, I think, with
Sorry, could I just ask you, sorry, what was your name again, just to make sure I feed back to you directly?
Councillor Graham Heaney from Portsmouth
Thanks.
St Jude.
Would you be able to feed back to all members?
Oh, yeah. I just wanted to make sure.
I just wanted to follow on from Councillor Healy about the finances, but specifically for Portsmouth. So you said that we have a small budget, really, in the grand comparison of the 400 million. Did we go into deficit as a...
So the way it works is that we have the 400 million. In terms of, as a whole, for Portsmouth, there was a small surplus of about 3.9 million last year. But to be honest with you, that's just not really how the whole situation works. It's more we work on, we've got the full allocation, and then so for example, we allocate 1/3 of the QA to the Portsmouth area that we look at, and 2/3 of that gets allocated when we're doing our sort of internal divisional accounts, as it were, to South East Hampshire. But that's just a sort of rough and ready description. So I think the way to work on it is that we spend what we can on each of our population, and as it says in the paper, it's over £1 million a day to Portsmouth residents, and we do the best we can with the money that we've got.
And I understand that. That's good, and it's nice to hear that Portsmouth are good with their money. So how is that going to now change now that the trusts are merging, and are Portsmouth going to feel the effect of other existing trusts misspending money or going into that deficit, and how is it going to impact Portsmouth residents?
I can honestly say that it's still the same pot of money that we will spend, because Isle of Wight, we spend on the Isle of Wight as well as we spend with QA, so it's the same spend. Clearly, it's difficult to articulate exactly what events happen. There are some of the restrictions that I mentioned earlier that we're trying to put ourselves under. The issue we've got really is it shouldn't affect them, but as some of the things that Caroline was saying is that how we get that best use of the money we've got and transform from out of the acute hospitals into community, that's the challenge we've got. So it's difficult to be explicit in that way. What we can say is that everyone's working really hard to get the best value and to look after the patients that we've got.
And sorry, just the last one on that. So you said about you're starting to save money via eliminating or getting rid of, to a nicer phrase, the non-clinical staff that are going through there. So that means that there's no clinical staff in the Portsmouth area, that we've put a freeze on recruitment or anything like that?
Do you want me to pick up the... So we haven't put a freeze on recruitment at all, because we've been really clear on the fact that actually services still need to run and still need to deliver. What the processes that are in place from an ICB perspective and in all of the trusts, because we've tried to mirror, are just a level of check and challenge around need. So each time there's just an additional process to go through, but within that process, a clinical member of staff is less likely to, be a post that's held than a non-clinical member of staff. So there isn't a recruitment freeze. There's just an additional level of sort of check and challenge to see whether there's something different that could be done, whether there are opportunities in terms of the skill mix within the workforce, but there aren't freezes within that.
Thank you. Councillor Minin.
It's okay, thank you. I have two questions. One is around capital investment. So we know that we've got an elective hub coming online soon, north of the county, to obviously address the knees and the hips, to stop people having their operations cancelled due to dropping down the list. From a Portsmouth point of view, are we accessing that elective hub, or is there any plan to do similar for south of the county? Thank you.
So the elective hub is for the whole of Hampshire and Isle of Wight's footprint. So the ambition for it is to, again, I suppose on the theme of making sure we've got best use of resource collectively, if we've got a hub that is specialising on a particular type of procedure, which means we can do it more effectively, more efficiently, consolidate clinical workforce, ensuring that that has best impact on all of our residents so that we can hopefully bring down waiting lists and make that a smoother pathway. So it will be for the whole Hampshire and Isle of Wight patch.
Thank you. And I'm interested to know what your ambition is around digital. And I speak as, you know, residents who get maybe 3 letters from different people, staff that have different programs that don't interface with each other, so they spend their time repeating what they're doing with different passwords and the wheel of death, etc. That seems to me, the NHS has more staff, more money, but less productivity. And I can't help but think that's because the systems are letting them down. Thank you.
So really good question, and we are in the process of refreshing our digital strategy for the whole system, and the reason we're doing it across the system is to address some of those issues around interface between different systems. One of the things that all of our acute trusts have signed up to is something called a single electronic patient record. So that should be then a common, it will take a number of years to roll out, but it will give us a single patient record, which means that we can streamline a lot of that communication and a lot of that, take out some of that duplication and that kind of friction between different systems. And then the other thing we're looking at is how we try and sort of make the best use of the functionality on the NHS app, because actually we're increasingly looking at that as being the kind of single way in for members of the public, because as you say, there's a multiplicity of stuff out there, but actually if there's a single front door into it, how can we best use that? And then there's a whole range of other things around, like you say, how we could enhance productivity by looking at some of our digital opportunities around that. So again, it's something that's in the strategy, but we do have some specific pieces of work coming up. I don't know if you...
And just to add to that, and you'll know from the Hampshire HASC as well, there's been a lot of investment in what we can do to modernise general practice in terms of digital phone lines, the use of apps, where we can sort of connect information locally, access to things like EMIS and other systems, Arden's templates, so lots of ways in which we can improve the flow and the referral from primary care into hospital and make that a lot more streamlined. So even at this most simple local level, there is investment going into general practice around digital improvement as well.
Do you have any follow-up questions on digital? Anyone else on digital? No. Councillor Williams?
It's not on digital, but it's on the first question that Councillor Meehan asked in regards to the elective hub relieving, in Winchester relieving specialist surgery, elective surgery in Portsmouth. I was wondering, and you may not have the figures at hand, but what proportion of elective surgeries will be relieved from Portsmouth hospitals in able to increase capacity at Portsmouth for more acute surgeries?
So you're quite right, unfortunately. I don't have them to hand, but it's another one that we can pick up and feedback unless we've got it. No, we'll come back to you on that one, but yeah. Good.
Members, any more on this issue? No. I've got Councillor Vernon Jackson next.
Sorry, it wasn't on digital, but so overall, Portsmouth used to have a system of integration between health and social care that worked extremely well, that produced budget surpluses each year, and where the feedback was that the integration was good. We seem now to be in a system where we produce budget deficits every year, and the feedback is the integration is less good than it used to be. why would Portsmouth want to keep being part of the ICB and not go back to a system that worked well and was financially stable?
So I think all of the things that we've described as our ambitions around integration and how we work together, absolutely, there is great work in Portsmouth. So nothing that we are aiming to do is with the intent of undermining any of the good work that's already in place. I think the key thing is to work through, for us as a system as well, where the impact is best at different levels. So there are things absolutely that the Portsmouth Place and Health and Care Partnership, Health and Care Portsmouth, is fantastically placed to do in terms of inequalities, in terms of understanding the population, in terms of that really deep ability to work with the communities. There will be some things where having that scale around particularly some of our services that might be more specialised or where there are cross boundary flows, so thinking about acutes, thinking about some of the mental health services, some of the things that we would want to do differently, where having a level of scale would enhance that in terms of removing fragility, removing the variation that people might have in access and experience. So I don't think it's either or. I think it's working through what's best done at what level of delivery, level of planning. So I think that's the...
So, sorry, beg your pardon.
No, sorry, because you did raise this at the last meeting as well. I know it's a concern of yours. I think there's a reality around the architecture, isn't there? We are now within ICBs. That's here to stay, and I think it's about how we maximise that. But just to give you some assurance, if you look at all of the transformation we're planning locally and what the messages are nationally, it is all about integration at a local level. It's all about developing services out of hospital. It's all about building on that strength of that local base. So I recognise your concerns, but in terms of what we're planning to do, that indicates a very different direction to travel.
But I don't think it's just Councillor Vernon Jackson's concern. At council meetings, it's universal, really, I think, across the councillors, and also, you know, speaking to residents and people involved in the system, people are very concerned about it. It's not just Councillor Vernon Jackson who's concerned.
So I think, thank you, useful answers, but, and I absolutely understand and recognise the will to try to do integration. I'm just disappointed that we've taken a system that did it and have broken it, and you're now trying to mend it. We used to have, when my great aunts used to do things that were really stupid and bad, we always used to say, oh, well, they meant well. But it kind of feels like that with this. That we had a system that worked well, was financially stable and produced the results we needed. It's now been broken by integrating into the ICB, where standards have been brought down and financial stability has been removed. And okay, it's great to see you trying to build it back up to where it was, but there was the destruction of a system that worked well. Is very, very bad, and means that the residents of Portsmouth suffer more than was needed. If we could go back to a system of coterminosity so that health and social care could work better together, that would be great. Hopefully the new government will understand that and recognise that coterminosity is important, because the evidence is that it delivered more financial stable things and better returns for the residents of this city. Hopefully they will be able to see that and be able to take Portsmouth out of the ICB as soon as is possible.
Okay, Councillor Heaney.
And I suppose what Councillor Jackson is saying is something that we've experienced over years, but I think there's an interesting point that you made about the finances, that in fact Portsmouth still does make a surplus. I mean, although the budget is much more integrated now. I mean, I think from my perspective, this idea that we could somehow declare UDI as Portsmouth and just become a little island on our own, doing our own thing, isn't realistic. I don't think it's realistic at all as a way to look at the system. I think probably what would be useful is if the other partners within the whole ICB were to look at what Portsmouth has done in the past, what has been successful, and then replicate that within the wider system. Now, that will take time to do, because obviously change always does take time. And there has always been a problem of getting good practice in particular areas replicated across the whole NHS system. It's, you know, it's a constant issue. You know, we've had lots of good practice in different places. You can go to any part of the NHS and find really good stuff going on, but it doesn't go on everywhere. So I suppose the issue is, how do you as senior managers encourage staff to work differently and to recognise the good work that's gone on elsewhere and say, yeah, we should do something similar. It won't be exactly the same, but that surely is a better way forward, I think.
So I have the very rare privilege of coming to work in Portsmouth in 2020 and have been through the change. And it has been daunting, but some of the work that does continue and has continued without interruption is being rolled out across Hampshire and Isle of Wight. So all of our preventative interactive health tools for My Healthy Mind in our teenage and schools is being rolled out across all of Hampshire and will soon be on the Isle of Wight. It just had to pause whilst they go through their restructure. Our neighbourhood team model that we've built up through our community assets, through our work in Paulsgrove, our work with our PCNs and our structure around our integrated community nursing teams for adults. That is the model that we have been building upon, and we've used our Better Care Fund money to employ more of those link workers to keep that going. It is change when you move into a bigger organisation, and that does settle, but we present our evidence. A lot of what we do is being rolled out. The rest of the health is no different in terms of learning from other parts. We're bringing in and have benefited from a lot of change that isn't always visible, perhaps, in terms of learning from other parts, but we are working. We just have to recognise we are still a system recovering from the impacts of pandemic and trying to put our finances straight at the same time. So it's an all doom and gloom, and we do get listened to, and we are held up internally and across the system as being exemplars where we do well, and we learn from others when we're not.
Any follow-ups on this issue? Sorry.
Yeah, and just to give a live example along those lines is I was at a Portsmouth meeting with local authority colleagues, and in one area of the ICB we had some issues with continuing healthcare for children. Bernie's nodding, she was there. And I asked if they could give some support with, because it was working particularly well in Portsmouth, if they could come and help me have some conversations with those colleagues elsewhere. And they did that, and we've got an improved situation. So yeah, there's definitely learning. That was I think that's just quite a nice live example to mention.
Any more on this issue? Councillor Van Jackson.
To pick up something from Councillor Heaney said, in terms of the finances, that in Portsmouth there's a surplus, but over across the whole ICB there is a deficit. Is that right?
It's not as simple as that. In the ICB last year made a surplus. It was the ICS, which has included all the providers, that made the deficit. So the surplus that the ICB made was part of the surplus that, part of that, a subset of that was what Portsmouth made. Yeah.
So I don't know if I'm asking for new members here, but probably for me, really, if I'm honest. But how do you get to the 10%? Is that done by, of the budget, is that done by population or health inequalities or need?
Yeah, there's various methods. There's, from a GP perspective, it's on a particular formula. There's also historic contracts. There's different growth levels that are given to it. There's a sort of sophisticated way that we work through along population, trying to get economies of scale. So, you know, like I said, 2/3 of QA will be paid for by South East Hampshire, 1/3 will be paid for by Portsmouth. So it's just a complete mix, blended mix of how we do that. Yeah.
And the other, it might not be a simple answer, I guess, but on page 21 of our report, page 9 of yours, just out of interest, is there an amount that is significant for the, should any of the capital plans change, that there would be a new published revised plan? Is there a level? That's on your page 9, I think.
Sorry, could you just clarify that question?
Yeah, on I think your page 9 of your report, which is page 21 of our pack.
Yeah.
It says, should our capital plans change significantly, we will publish a revised plan. Is that when it gets to a certain level that there's a change, or some other reason? Do you know?
Yeah, I think it's purely a sort of caveat. Should things change nationally and they make decisions that we either get significantly more or significantly less, you know, it's just we have to be able to adapt and adjust depending on what happens nationally. So I think that's just a sort of overall caveat to say that this is the plan as it stands at the moment, but be mindful things could change.
Thank you. Members, any more questions? No. So thank you very much. So your report is noted. You're welcome to stay for the next item if you're not on the next item. Or you're welcome to go as well. Your choice is yours. So thank you very much. So next we've got agenda item 5, which is health and care Portsmouth. So I'll let you. Hello. So could you introduce yourself for people who might not know once you've settled down? No rush.
That I actually am also the chair. I have an integrated post under section 113 and I'm the chair of the Health and Care Portsmouth Partnership Board, and obviously Bernie is our NHS colleague who's the place director.
Thank you very much. So we've read the report, and what we'd like is if you need to give a brief summary of it or any changes since the report has been published, and then members will ask questions. Thank you.
Happy to do that, Chair. So no changes since this was published, but in light of the previous conversation, I just wanted to make a few points that are within the report and a few that might help clarify. So you'll all know that Health and Care Portsmouth Partnership has run for many years. It's not new. However, there have been some recent changes and we have refreshed our plan and some of the governance because of some of the changes that we've just talked about. So, and I think in light of that previous conversation, so I just want to say, obviously, I think a point that sometimes didn't come up in the previous conversation is that Health and Care Portsmouth is a partnership. So obviously it includes NHS, Hampshire and Isle of Wight, the ICB, but there are 5 partners, which include the GP alliances locally, QA, Queen Alexandra Hospital, our own Portsmouth Hive, the voluntary sector organisation, NHS Solent, who I know, obviously know, are going into the new Health Hampshire and Isle of Wight NHS Community Foundation Trust shortly, but also obviously the council, well, importantly the council and the ICB Portsmouth team, NHS Hampshire. And it's important to state that because it's not just, it is 5 partners. However, there are some differences in approach, which I wanted to mention. So as it's really important, so in terms of quickly the governance, because it has changed subtly, obviously we sit in Portsmouth under the partnership around the Health and Wellbeing Board. So the Health and Wellbeing Board is at the top of that governance, and we have obviously a health and wellbeing strategy, which is much broader than just health and care, because obviously there are other aspects which I would call, you possibly heard me talk about this. Our strategy is based on the causes of the causes, the wider determinants. So obviously air quality, these are aspects that impact on health. Positive relationships, housing, educational attainment, all part of that. But we take in Health and Care Portsmouth in the partnership into our action plan, the aspects of the health and wellbeing strategy that need to be delivered by health and care partners locally. So we've got the broader partnership, which obviously includes the university, the police, the fire service and others in Health and Wellbeing Board, and many aspects of that then are delivered locally. So that's our partnership. The governance sits there. We've got the Health and Care Partnership Board, which, as I mentioned, I chair, and then underneath that we have got, which I'll talk about, we've got 5 priorities. Those have been refreshed, but they're not different from where we were in previous years. So they focus on children and young people, health improvement, reducing health inequalities. It's in the report, adults with complex lives, integrated community care model, or I'm just going to say Better Care Fund, and person-centred care, continuing health care. And what's important about the refresh is that we are ensuring that we're now updating our plans in line with. So obviously it has to connect into health and wellbeing strategic direction, but it also takes into account the Hampshire and Isle of Wight NHS system priorities and the integrated care partnership. So I won't go through them, but there are 5 priorities there as well. We ensure that we then map those into our priorities locally. So what we are doing in effect is ensuring that, as Caroline mentioned, we at the system level, we look at the strategic direction and where we can work and make impact together, but we also then deliver that locally, ensuring that we feed back on how we're delivering that locally through our own plan. So I think that just kind of describes, I would like to say that integration continues. The bit that's changed is that obviously we were moving and having integrated budgets, or rather more aligning budgets, around our Section 75s. That hasn't changed, but we've focused that where we actually get the most, I think, most effective delivery around what's shared between us, and it is mainly around the adult social care agenda. So where we still have pooled budgets and pooled integrated teams around our Better Care Fund, as we talked about in the previous paper, and our continuing healthcare. And it was nice to hear from David the success, because it is a very successful programme, particularly around continuing healthcare, because we don't have 2 separate teams, 2 separate budgets. We have one, and that definitely reduces where we get into conflicts about who's going to pay for what, but also importantly it does ensure that actually the patient is at the centre and you get the best delivery out for the outcomes of that individual. So we don't argue. I'm not saying we don't sometimes argue around budgets, but not around the continuing healthcare as much, I would say. So there are successes. We've talked about some of them. There's examples of where successes in the paper. And the one bit I didn't talk about was P3, or what we call our provider partnership boards. And that is where we will bring all of our clinical projects together. So we've got all of the, from each of the providers, we've got all our clinicians together, and we look at opportunities, and there's some examples there in the P3 board where we've actually worked together. So lots there. I'm not saying, you know, there are challenges, not ignoring the financial challenge, but the whole purpose and what has changed is that we don't necessarily have governance together. We maintain our governance in each of those 5 organisations, because that's where the decision making has to happen. However, we come together where it makes sense to come together on actually delivering projects together. And there's a really nice example around homeless healthcare, the work that we're doing together around the integrated neighbourhood teams, and also the work we're doing about the asset-based approach. And the importance is, I just want to state it is about that broader partnership and what we all bring. It's not just, because I think again sometimes it's not just about the NHS, because obviously you've got several partners in that are the NHS, but you've also got how we work the voluntary sector, how we work with business, how we work with the university. We've got a big programme of research work through the health determinants research. So lots happening, but it's where we come together, because it makes sense to come together to actually work on things that are going to improve outcomes for our residents. So that, I think that's important, because the NHS have to deliver what the NHS needs to do, but actually where we come together, it's where it makes sense because of that prevention agenda. Yeah.
Thank you, that's really helpful. So open to members. Any questions? Councillor Vernon-Jackson.
Helen, on page 38, there is a graph about general practice that either yourselves or colleagues might be able to talk about. And there are two grey lines, and I am attempting to interpret what the different grey lines are. But I think the lower grey line, indeed, yes, I think I've guessed right, is the percentage of people who are seen that day in GPs. So I've sat in a GP surgery in Portsmouth when they open the doors at 8 o'clock in the morning for appointments for that day, and by 8:10, all of them have gone, and everybody who turned up after 8:10 didn't get one. And my experience then of going to our one is you might get something in 2 weeks' time. This is saying that 45% of everybody who wants to see a GP sees them that day. And that, to me, does not seem credible in terms of the experience either in my GP surgery or having sat in a waiting room. Is this people who are wanting to see people face-to-face, or is it including people who are seeing online and telephone, etc.? Because this just doesn't seem...
Be face-to-face.
So I'd be very interested. Could we have it... Is it possible to have this broken down by practice? Because this, from my experience in the city and having talked to residents around the city, does not look even remotely credible.
So that's the position, and it is improving in Portsmouth.
Which is brilliant.
There's still a long way to go. I think at the last meeting I suggested I would bring back a more detailed overview of general practice activity, which does break it down by GP practice. I think that's helpful in terms of context. It'll have to be a presentation, Chair, because of the nature of the data and how we have to present it, but I'm quite happy to come back and do that.
It would be really useful. I mean, so it's not about my personal experience, but at my GP surgery, you know, that doesn't, I know out of if I've contacted them 10 times in a year, that isn't, so it'd be very, very useful, let's put it that way, to see which GP practices provide that service on the same day, because there must be some that provide 100% to make this figure.
Just, sorry, Councillor Jackson, your point around sort of the 8 a.m. issue, I think one of the things we are focusing on is how we tackle the 8 a.m. rush. So you'll see through our work on the Primary Care Access Recovery Plan, we've put more call handlers in, we've put care navigators in, we put more of a triage team in to answer calls at that time of day. And there will be instances where certain calls are prioritised based on clinical need. You'll be given the option to see a pharmacist, a nurse, be seen online, go to your pharmacy, etc. So that is improving. The ability to respond to that need early and give the patient a plan is happening, but clearly we need to take that a bit further in terms of a wider pool of patients.
So is the 45% figure then if the clinical need is to be seen that day, or is it just if anyone rings up?
It would be all patients, but clearly some patients would have different clinical needs. So depending on your clinical need, you would be seen by a GP, or you could be seen by a pharmacist, you could be seen online. It depends on your particular need on that day.
So I've got Councillor Heaney next on this issue.
Yeah, we're sort of Mark sort of picked up on the point I was going to make, because clearly, I mean, somebody might want an appointment on that day, but may not need an appointment on that day, and someone else needs it more urgently. I mean, I went into surgery and booked an appointment, but I didn't need it on that day, and booked it a few days later. So the figures, in a sense, sort of give a slightly false impression, don't they? Because it's difficult to know. I mean, if somebody's being triaged and say, well, actually, you don't need an appointment, you need to go and see X. Is that counted as a seen within time, or is that, you know, how do we get a more accurate sense of this? Because I get a feeling that the figures sort of, it's like whoever turns up on the day, and it doesn't give a really accurate picture.
And that's why I think giving a wider picture across a wider range of practices would be helpful, because then you can see how we categorise, how we split it by professional groups. I'm not seeking to swerve that, but I think that context is important.
Any more on this issue?
Thank you. I've asked this at HAS, so I apologise if you've heard it before. Just talking about people who come to the GP, obviously you've got your frequent flyers. Have you got anything anecdotally that says that social prescribers have reduced that demand and in doing so freed up more appointments for other people? Thank you.
And actually, following your point a few weeks ago, myself and the Clinical Director for Primary Care are looking at how we're using social prescribers, where they're positioned, how they're utilised, because we think there's a huge opportunity there, not just in terms of redirection, but also health education and supporting people. I was at a conference yesterday, and there was someone talking about the work that social prescribers did in supporting patients to maximise their medication and continue with their care plan. So I think you're right, there's more we can do, and we've got to use them more as a simple navigator of care. We need to use them as part of a patient's ongoing care where we can. So I think there's huge opportunity there.
Did you have any other follow-ups on this issue? No? Okay. Any other members on this issue? Any other questions? Councillor Van Jackson.
Thanks. Last report, I've been thinking about it over time, and it's got me more and more concerned. And that was about the number of the percentage of dentistry NHS units that were taken up in Portsmouth, because there's an enormous demand for NHS dentistry in Portsmouth, which people find very difficult to access. And I just want to make sure that I've understood this correctly. But the figure from my memory was that only 38% of the units of dental activity available to be used in Portsmouth were used last year, which sounds very bizarre if we've got money being allocated from the NHS. Now, okay, have I got this wrong, Helen? Tell me what I've got wrong.
I couldn't give you the exact percentage, but I know it's not 38%. I checked that after I know we're meeting imminently.
Yeah, but can you see if you can find out what it is?
Yeah.
Just because it was, and I'm overjoyed that I'm wrong, because it was absolutely terrifying.
Can I just come in? I think it was part of your example that you gave out of 100. You just said 38 out of 100 spaces were used in that. I don't think it was a percentage.
Yeah, I just need to be clear what particular service it related to and what context, but we will get back on that because it's clearly a concern.
That'd be very kind. Thank you very much.
Any more questions on this issue? Any more questions, members? No, thank you very much. So we'll note your report. You're welcome to stay for the next items, but equally if you want to go, do and have a nice evening. Thank you very much for coming.
It's the last sunny evening of the summer, isn't it?
Thank you. So next is agenda item 6, Portsmouth Hospitals Trust. So would you like to introduce yourself, please? Thank you.
Hi, my name is Peter Ridley. I'm the Chief Officer of Portsmouth Hospitals.
Thank you very much for coming. So, Peter, we've read your report, so could you give us a very brief summary and alert us if there's been any changes, and then members will ask you questions. Thank you.
Yes, of course. I mean, so I won't go through the whole report. Just a few things to draw to your attention. We start with the performance around our emergency department and urgent care generally. It is so important to us, isn't it? And we know it's an area of challenge and continues to be so. So it is worth me just spending a second there. We describe our performance in July. Our August performance was slightly lower than that. So we report 66.1% against the 4-hour target of 65.5% in August. So I just want to say it's deteriorated a little in August. And we know we have challenges with ambulance handovers and ambulance holds at the front door. So I just wanted to be clear about that we know we're under pressure at the moment, and particularly in the last couple of weeks. The other thing to point out is part of that is our ongoing work we need to do internally and with partners around those patients who no longer need to be with us, who would be more appropriately in a different setting. So there are no criteria to reside patients. We are doing a lot of work on discharge at the moment, and as we talked about in one of the earlier items, we have a lot of work still to do there to make sure not only are patients discharged when they're ready to be discharged to free up flow in the hospital, but also to make sure those discharges work for those individual patients and people end up where they need to be at the right time. The only things I was going to pull out really was we're doing an awful lot of work at the moment on what we call building better emergency care. That is broadly our new emergency department that is nearing completion now. It is much bigger than just a building project. It is all about the clinical pathways that go around that and how the whole hospital works, and indeed how partners work with a new emergency department, so taking the opportunity there. But that is on time and on budget at the moment, and that will be a significant development for us going into the winter. I wasn't going to pick out an awful lot more other than to say I'm very happy to answer any questions you've got. Clearly, there's an awful lot of work going on in development around the site, a new endoscopy unit. Those that have been recently know we've been developing our entrances to the hospital, which has caused a little bit of it's caused a few issues with moving people around the site, but we'll end up with much better facilities at the end of it. So there's an awful lot of work going on around the site, which is fantastic. And we continue to work to treat as many patients as possible, but clearly we're coming into winter and we're doing a lot of planning for how we get through the winter period. But I shall stop there and just answer any questions.
Thank you. I was there on Tuesday and the entrance is impressive.
Yeah.
Thank you very much. So open to members. Do you have any questions? Okay, I've got Councillor Vernon Jackson.
Well, just a very simple one, Peter. So Penny is Chief Executive
Yes.
of what, and you're Chief Officer of what, and how does it, is there any communication or how does it operate?
Yeah, that's absolutely fine. Yes, so Penny remains Chief Executive of Portsmouth Hospitals. She is also Chief Executive of the Isle of Wight. So she's Chief Executive of the two separate organisations, and so does work across the two. We also have a lot of common executive members. I'm one of the few executives who isn't common across the two. I do sit on the Isle of Wight board, but my focus is all on Portsmouth. So Penny is over the top. I report directly to Penny, and I'm responsible for the day-to-day operations of the Portsmouth site and the strategy of it, but working to Penny.
Thank you. Yeah. And in terms of the north entrance, I understand that all the work is to create a new Costas. Is that true?
So there certainly will be a new cost. That is part of the development.
And money-making schemes.
So in terms of that scheme, yeah, there is a new Costa, which will be a good facility. There'll be new changing facilities there, particularly changing facilities for those who need
baristas or.
I'm sure they can use them, but for members of the public, will also be additional research space on that first floor. So clearly, there's some commercial outlets that will go in there that will provide services to patients, and clearly that helps pay for the overall scheme. But there's research space too.
Please, not burgers. At Southampton Hospital, you used to go in, be welcomed by the smell of Burger King, which was just terrible. Costas are great. Having sat in A&E through the nights a lot, it's there all night, which is really, really helpful. And a very good service. It's costing me a fortune, but it is a very good service, and being there 24 hours a day is really helpful for both staff and patients. The other bit, just a tiny thing, I just thought it was a really good small thing that you've done to recognise the waits people have in A&E is providing sandwiches for people. It's just realistic to say you're going to be there for hours, and you might not have eaten anything, and it is a really small thing, but I thought really thoughtful.
Thank you for that. That's really helpful. We know people wait too long in that department, and clearly we need to do something about it. But we need to keep on thinking about kind of the human side of that, don't we? And what can you do to make it a little bit more bearable?
Any more on Costa or sandwiches? Except I'm getting hungry. Any other questions, members? Councillor Heaney.
You mentioned the... Oh, sorry, were you first? No. You mentioned the average beds occupied by patients who no longer meet the criteria to reside, so over there. Do you know whether there's more delays from particular areas, i.e. where those patients come from, I mean, obviously Hampshire is key, but Portsmouth, I mean, have you got any idea where those delays are? Are they more in one area or is it just a bit random?
So I wouldn't say it's random. There are certainly more patients from Hampshire County Council than there are from Portsmouth, but equally we have more patients from that area. So I would say I wouldn't say that they're enormously differential. Clearly, we know for every one of those patients which area they're from, and also what we are doing, working really closely with partners on a daily basis now, is understanding actually what is it those individual patients need in order to get to the right place, because there is still clearly a role for the hospital to play, even if there isn't no cryotheatre reside to support that. But there is more from Hampshire, but equally there are more patients from that area too.
Do you have any follow-ups on that? Any more on this issue? So over to Councillor Williams. Apologies, I missed you.
No, that's all right. And I envy the Portsmouth staff, having worked a decade at Winchester, the ability to have a Costa coffee open 24/7. My question was around the Safe at Work campaign. I know in the documentations it mentions about the increase in national instances of abuse and violence towards staff. Are you seeing that trend similarly in Portsmouth in QA as well?
Yeah, no, we definitely are. So yeah, we certainly don't book the national trend, so we do see an increase in violence and aggression. We definitely, I believe we see more reporting of that now. So it's hard sometimes, isn't it, to describe that over a timeline, because we do encourage people to report it and to understand where that's happening and the nature of that, and people to report incidents, because it just gives us more ability to try and do something about it, doesn't it? But we definitely have seen an increase, and some of that increase is real rather than reporting.
Did you have a follow-up on that at all? Any other on this issue? Any other questions, members? Councillor Jackson?
I don't know, it may not be something that you record, but it's very noticeable in QA that very large proportion of the nursing staff seem to come from abroad. Is there any work that, any reporting in terms of nationality of workforce that you have and how that's changed?
Yes, so we've got very significant numbers of particularly nursing staff, but not only nursing staff across the trust who've come from other nations to work with us. We've had quite a concerted effort for 2 years to fill particularly our nursing vacancies on the wards, and international recruitment's been a very large part of that and has added greatly to what we have in the organisation. And we have all sorts of things in place to support those staff, kind of ensure that they're settled, that communities are supporting each other, and that we are developing those staff with the skills they need. So we do record that. I don't have any of those statistics in front of me, but actually, yeah, we do have a significant number of international staff with us now who are contributing greatly.
So can I ask, what's the issue with recruiting British staff? Are people just not being trained, or are people leaving the profession? Why is there such a significant issue, particularly in nursing?
So it is availability. So there is a national workforce plan that was published last year by NHS England, which sought to increase training of staff of all sorts within the NHS over the next 10 years. So it's availability of those staff and able to recruit them. We do have very active apprenticeship schemes. We work with local colleges as well, and actually have got some amazing, enthusiastic young recruits from that route. But there isn't sufficient, we just can't recruit sufficient numbers from the UK in order to fill that. I think over time we'll continue to focus on any avenue we can, and we'll continue to work with local universities and colleges. Yeah.
Is it the same issue?
Yes. So one of the pools that would normally seem to be a logical route would be healthcare workers who are not currently nursing. And the feedback I had talking with people was that it's now so divergent that the nursing stuff is not really about caring for people. It's about giving out medicines and checking obs. That those people who go into being healthcare assistants because they like looking after people don't want to progress to become nurses because it has been so professionalised. Is there a different way of those people being able to enter the nursing area of work, because they are such a good and strong pool with such incredible experience and expertise, but who the feedback I had from several was that that it was just not about caring for people anymore?
So we have a large number, don't we, of the non-qualified healthcare assistants, healthcare support workers, staff who did a brilliant job. Frankly, we couldn't run without them, could we? Clearly. We do support a number of those. If they wish to kind of move on with that qualification and go into nursing, then we will. Clearly, that qualification around nursing is important, and nurses do more and more over time, don't they? And actually their ability to prescribe and to carry out treatments of various sorts has developed over the years. What we are trying to do is have enough new and different roles so that we can utilise the skills and the development that anyone wants to go through. So actually what you've seen over time and what we'll continue to do is actually blurring some of those boundaries and making sure we have different types of role in the organisation so we can support people to really develop those skills so that they can carry out that work, and those that are maybe more qualified we can make sure are focusing on the things that only they can do.
Thank you. Councillor?
Just following on from Councillor Vernon-Jackson, apologise if I'm incorrect. I understood the reason with the nurses was the fact that they had to have a degree, and obviously a lot of people don't want to incur that huge debt. So, and I also understand that's why we're going towards apprenticeships for nurses as well, and I understand that's why there was a severe reduction in local population, shall we say, taking up nursing.
So we definitely support apprenticeships. You're right around, I guess anyone getting a degree, that's quite a big decision at the moment, isn't it? I couldn't really comment on whether that's stopping people going down that route or not. I probably don't have the data for that. But we are seeking to create as many avenues as possible for anyone who wants to get in, anyone who wants to work for us and deliver the kind of care we'd like to deliver, that we've got, that we utilise their skills, because we're going to need to.
Did you have a follow-up on that at all? No. Councillor Tyndall?
Yeah, it's just on the occupancy levels. Excuse me. Is that based on just the QA and not St Mary's and any of the local Jubilee?
Yeah, they're all figures for QA only.
Okay, and what is stopping those 213 people coming out if they're clogging the system up?
There's a whole host of reasons. So there are a number of patients who require the appropriate assessment to understand where they need to go to next. There's those who are waiting an appropriate placement to be available. There is funding decisions to be made around some of those, right the way through to some patients who just need the appropriate equipment or home modifications in order to go home. So there is a whole raft of reasons as to why those individuals can't go home, which is why it's so important that we have this weekly process with Portsmouth and Hampshire councils in the room, along with Southern and Solent and ourselves, so we can literally go through each of those patients to make sure that we're all taking the actions we need to try and reduce that number.
Did you have any follow-ups on this?
Yeah, it's just, is there any plan to use St Mary's more to try and alleviate some of that? And I suppose it links in with a bit of the emergency department about the walk-in centre as well, and developing that area to, again, alleviate and use the south of the city a bit more rather than just the north.
So the urgent treatment centre at St Mary's we don't run, but is incredibly important to the overall urgent care of the area, as is Gosport and indeed as is Petersfield. So making sure that we are working together. And actually there's an awful lot of links between the emergency department up at the QA and those 3 units to make sure actually we're talking all of the time and indeed sharing resource on some occasions. I'm not aware of any plans to develop that unit at St Mary's or indeed for us to look at providing any more beds down there to alleviate this number. Clearly the work that's already done at St Mary's is really important to what comes to QA and what doesn't come to QA, and some of the elective procedures that happen down there are really helpful to keep kind of that flow going. Again, it's not our activity, but it's really important.
Councillor Tyndall, did you have any follow-ups? No. Councillor Vernon-Jackson?
I remember talking to one of the predecessors of the chief executive of the hospital who was interested in QA bidding to run the St Mary's Urgent Treatment Centre, but they were not allowed to bid for the contract. The government wouldn't allow them to bid for the contract. It had to go to the private sector. It couldn't stay within the NHS. Would you welcome the chance to being able to bid to run that so there's some integration?
So clearly it's a service commissioned by ICB colleagues, and it's for them to decide actually how they wish to commission that and how that is procured. I think it's less important who runs that service and more important that we are linked with them and we understand which patients need to go to St Mary's and which really do need to come to QA, and that we work between us to make sure that that patients understand the appropriate pathways and get the support they need. So I don't mean to sit on the fence too much, but I think it's much more important actually that we understand the pathways for patients and are working closely together rather than who actually runs the facility.
Members, are there any other? Yeah, sure. Yeah.
Not on the, but picking up Councillor Tyndall's point and some of the other points about the nursing thing. So, if nursing is now a degree-led thing, and that meant 50% of youngsters go to university to get a degree, but 50% don't, and nursing was often seen as a route into a profession for people who didn't want a degree, and whose families maybe going to university was not in their history and tradition. Are we losing out and excluding a big proportion of our population from being able to enter a profession that provided a really good area of work for big numbers of people who came from poorer backgrounds, for whom university was not something that they felt happy and confident in, particularly ending up with a debt of 60 grand at the end of it, that mummy and daddy wouldn't be able to pay off. Is there a route of being able to open up nursing to those people for whom that route's been closed off?
So I think it's incredibly important we support apprenticeships and other ways of people coming into the profession. I can't really talk for the nature of degrees in nursing and kind of that national position. I think it is incredibly important we support anyone who wants to come into the nursing profession, to give them an opportunity to do that. I think it's also really important we recognise that nursing is a profession. And actually what our nurses do every day on the wards, in clinics and elsewhere, is actually deliver very technical care to patients, and with a skill set is really important, and does take the years of training they need and the level of experience they need to safely carry out that care. So I think it's really important we have those staff to care for our patients on a day-to-day basis, but also recognise the professionalism of our nurses. Actually, they are delivering a professional service.
Yes.
Sorry, we're having a conversation here. Thank you, Chair. No, you've just struck me there, because one of the problems, and I would hope that perhaps the NHS can learn from the police, one of the problems we had was recruiting officers because they had to have a degree, or they would go into their apprentice degree when they were working. And as a result of that, we really struggled to recruit. So certainly in Hampshire, we now, that's not a requisite. So I just think, like you say, we want to harness as many people as possible, and not everybody, is designed or has that ability. I understand that nursing is a profession, but I'm sure, you can achieve and do the job, perhaps, in a different route. Thank you.
No, I agree with you. Councillor Tyndall. Yeah.
Just to follow up on that, so what do Portsmouth Hospital do to recruit nurses, and is there a big recruitment drive and promoting the apprenticeships to then work in QA?
Yes, no, so we have a number of routes really. So yeah, periodically we will do that international recruitment piece, but more regularly we have fairs where we encourage people to come along. We try and link into the various cycles of universities around bringing in the new nurses. We are generally out to recruitment for some cohort of nursing one way or another. I don't generally have the concern, and my CFO doesn't, that we're going to be over-recruited on nurses anytime soon. So we're constantly in that, trying to attract nurses and trying to make sure that the experience of those staff is fantastic, so that actually they stay with us. So one of our primary priorities this year is actually around retention of that workforce, because actually you put an awful lot of effort into recruiting those nurses, don't you? But making sure that those nurses are supported, feel as though they are coming into work each day and feel that they can do the job that they are there to do is really important in trying to retain them. So we have retention targets for each of our services.
Anyone on that? No? Yep.
Thinking things that the council can do to support. If we've got an increasingly large number of nurses from outside the UK, some of whom, this may be their home for life, but some of them will be here for a while and then go back. In terms of shared accommodation, is that something that's an important thing in terms of retention for nursing staff?
Yes, in a word, it's really important. So accommodation that makes it easy for them to access the site, particularly in those first weeks and months when we have international nurses, and actually where there is mutual support from nurses who we've recently recruited. Accommodation is something we talk about quite regularly because it really does help in terms of both the recruitment and retention piece as well.
Thank you. Any other questions, members? Oh, Councillor Williams. Yeah.
Unrelated to the current conversation, but it was just to pick up on a comment mentioned earlier in regards to productivity nationwide, in regards to the NHS and sort of, you know, many studies and people identifying that is an area that needs improvement. Do you have, and I love metrics, so apologies for putting you on the spot, but do you have metrics that you could come back and give us in regards to, say for instance, delayed or cancelled operations due to missing equipment, or delays, you know, where I'm particularly talking about theatres because it's one of the most expensive parts of the hospital to run, but whether, you know, you have been doing investigations into those sorts of areas where productivity could be increased due to, say, missing equipment and delayed surgeries, that sort of thing.
Yeah, no, we do have a lot of statistics around operational productivity and particularly around theatres, because you're right, it's such an expensive resource, isn't it? If I can take it back to, I shouldn't really be talking about the money, should I? But actually our ability to use that finite resource for as many patients as possible is the key, isn't it? So we have, lots of statistics around, any cancellation in theatres and why that is, the utilisation of those theatres, constantly checking on, did we start on time? Did we finish early? And in individual services, how many procedures did they manage to complete on that kind of half-day or full-day list? So I'd be very happy to bring some of that back, and it's a real focus for us at the moment because, it is a finite resource, isn't it? And we need to make sure we're making the best use of it.
Members, any other questions on this agenda item? Thank you. So we'll note your report, Peter, or the Hospital Trust report. So thank you very much for coming this evening. You're welcome to stay for the last item, but you also leave as well. So thank you. So the next agenda item is Health Watch Portsmouth update, and it's Siobhan, isn't it? Sorry you've had to wait. It is. Would you like to introduce yourself and
Siobhan McCurrock, I'm the Health Watch Area Director for Hampshire and Portsmouth area.
Thank you very much. So we've read your report, so if you want to give a brief summary or give us any updates on the report, you're welcome to, and then members will ask you questions, so thank you.
So thank you. So we prepared the report with the intention of explaining about Health Watch in case members were new to the committee and did not know Health Watch. So I hope that has given an indication that being as a patient champion, taking people's feedback and giving that to people who make decisions to help shape services and achieve improvements is our modus operandi. 1,500 people in Portsmouth interacted directly with us. Our mission, the Health Watch England does a generalised mission, which is in the annual report, but certainly in Portsmouth, our work plan is generated from people who contact us and tell us what the problems are, and we base our future work on what people are telling us are their priorities. We also link in with the Health and Care Portsmouth plan and an awful lot of things that appeared in my report have been discussed this evening and are reflected in our work from last year or work currently. So if I may just turn to a couple of the slides to give a bit of context. So with regard to the GP appointments on page 5, there was a quote, and this may well ring true with a lot of people who've had this feedback in the last 12 months. Don't forget, this is previous rather than current information. I was asked to provide for 23-24 feedback. Great that there is an additional capacity in the system to offer appointments. The questions I was going to be asking members to consider, and indeed colleagues who are the system drivers, to look at increasing the opportunities for using that untapped resource of the social prescriber, and whether it's possible for care navigators to directly refer to social prescribers rather than it requiring a GP appointment to reach the social prescriber, because 85% of demand into a GP surgery, that's not just for GP appointments, but that's 85% of demand going into a surgery, does not need a medical response. Now those are Hampshire and Isle of Wight ICB figures, so that must tell you that the navigation of people's requests into the surgery needs better management if there's so much demand and not enough supply of care. So I would look to having yet more conversations with leaders to encourage. I was delighted to hear that there's an increase in use of social prescribers, but I feel that it's an untapped resource and more could be done to get that opportunity for the patients to feel confident in being navigated to a social prescriber, but equally being triaged by that care navigator, because they are the essential element of when people contact a surgery, and I don't believe not enough is known about the care navigator role. So that was interesting on primary care. With regard to dentistry, on page 8, where we were talking about the impact we had, we were talking about finding details of where dentist practices were taking on NHS patients. We developed a website page specifically to provide an update as and when we heard where surgeries in the city were providing additional appointments through time at the odd time when there was additional funding provided and contractors took up those appointments. We made sure that we provided that information, and often the largest number of views on our website and social media related to when we posted about additional appointments available in the city. One of the things that I fed back to NHS England on the Dental System Reform Patient Partner Voice Group, snappy title, was with regard to the NHS dental contract needing reform, because that was a sticking point for a lot of dentists making themselves available to provide NHS appointments. I'm pleased to say that things are moving in that direction, and dental reform is looking at the actual contract itself rather than just looking at flexible commissioning, which is where we were previously. So with regard to urgent treatment centre wait times, we challenged the information, and this was provided on an app called Waitless. We were concerned that urgent treatment centre wait times were held alongside the emergency department wait times presented to patients to say, well, if you go to QA, it's a 2-hour wait. If you go to the urgent treatment centre, it might be a 4-hour wait. People would be making decisions, well, I'll go to the QA because somebody's telling me I can. So we challenged that piece of information to be removed because it was inaccurate in terms of adding in wait times for an emergency department, when the whole point was that urgent treatment centre information was only what should have been on the app. And there is still work going on that, but I believe that the app is, the Waitless app is going to be amended. So in terms of hard to reach groups, we were talking about it at the bottom of page 8. We continue to expand the groups of people we're trying to reach, and on page 10, is it page 10? No, it's page 12. We are looking at speaking with children and young people who have been experiencing difficulties in accessing mental health services across the city. Particularly,
sorry to interrupt. Would you just mind showing? Is it the 12 that page 12 that we've got?
it's page 12, the slide, page 12. So it says work plan 24-25.
Thank you. Yeah.
Sorry, I'm sort of rattling through it.
It's me.
Okay. So on slide 12, shall I say, with regard to point 3, urgent and emergency care, patient pathway, we are planning to actually undertake a walkthrough at the new emergency department to actually look at what is going on when patients are going in to that service. So I'd be very happy to work with PHUT colleagues to actually say, well, this is what we're discovering, these are the issues, and ask questions with regard to that activity. With regard to point 4, which is something I'm currently working on, it's the Health Inequalities Research Project. At the moment in the city, we are speaking with communities who are affected by health inequalities and asking them to tell us how to achieve the solutions that appeared in Part 1 report. And I'm delighted to say that on the 6th of November, the Health and Wellbeing Board have organised a development session looking specifically at the Health Inequalities Research Project that I've developed with Healthwatch Portsmouth, to actually get people in the room to look at ways in which to take the initiatives forward that the community has said need to be done in order to make change. So I'm very pleased that the Health and Wellbeing Board members and the wider community that supports a development session meeting will be looking specifically at those issues, and they will be very current, that are being gathered at the moment across the city. So those were some of the points, but I've taken away an awful lot of information of things that have been said tonight, including work on a future commissioning scrutiny of the Accessible Information Standard. Again, we did a report and looking at compliance, and we have generated through the Integrated Care Board at Hampshire and Isle of Wight level a steering group which is scrutinising trust compliance with accessible information, which supports people with additional communication needs to be able to understand the information that they are being provided with for health and care services. So that again is an exciting piece of work that I shall be working with colleagues in the Integrated Care Board. I'll stop now.
Sorry to run away, I've got another meeting elsewhere in the city at
1:30. Thank you. I read it last night. It's really sort of well laid out and useful report, so thank you. Members, do you have any questions? Yes, Councillor.
Thank you. It was really about the exercise referral scheme. I think
Right.
I certainly anecdotally know from residents, now I'm obviously speaking from Gosport, that very often GPs don't mention it as a matter of course. So I would suggest maybe that sits with your social prescribers.
Indeed. Gosport is outside of the area of Portsmouth, so that would be handled by Healthwatch Hampshire. But nevertheless, yes, exercise referral schemes. There's often a problem with the funding of where that exercise is taking place. So whether there is a voucher scheme for people to be able to use at the leisure centre or another facility.
Just if I can just finish, Chair, just following on from that, certainly we have statistics that show of the people who do the exercise referral, 70% who complete it then go on to sign up for whatever leisure centre it is for full membership. 80% of them do. But I don't think it's promoted as well as it should. I certainly don't think GPs discuss it mandate, as in everyday sort of conversation I'll have with somebody.
So in the city, there is a project in Landport, Healthy Activity, and we have linked that project with an additional project in the city, because two things were happening and neither side knew. So a lot of the work that Healthwatch Portsmouth does, because we go to an awful lot of things, we don't dive down deeply, but we have a very broad remit. We connected the two projects. So we're hoping that with more awareness of what's going on in the city, as you say, Councillor, the opportunity for improved referral would be taken up. But certainly, if when we're speaking to the Landport community team about exercise, if we ask about the exercise referral scheme and how social prescribers are being utilised to get people into those schemes, that could only be a good thing.
Do you have a follow-up at all on that?
And it was just to say as well that we can also offer people with PIP. They get half-price membership, and the carers go free. So I think it's removing all those barriers.
Absolutely.
To encourage people.
Absolutely.
To be more active. Thank you.
Thank you. You've got Councillor Tyndall next.
Yeah, just excuse me. Just one other point I picked up right at the start about, you said that you only interacted with 1,500 people across the city last year. I'm just really intrigued to see what you're going to do to try and increase that number, because it seems really low.
That's face-to-face. So in terms of electronic, we have thousands and thousands of people that we connect with, but that was just people who came to us at information stalls, or we met at an event, that sort of thing. Yeah, so it's many thousands we have in contact, and our website is well viewed.
Members, any other questions? Thank you very much. Sorry you had to wait such a long time. I think next time it would be fair that we put Healthwatch at the top of the agenda. that's a promise I'm making as chair.
Lovely. Thank you very much.
Thank you very much.
You're welcome. Thank you.
We'll note that report. So it's the end of the meeting now. So thank you, members. That's all on the agenda today. The next meeting is on Thursday, the 21st of November. So I officially close the meeting and ask Lisa